Okay, so we will start off with our classical hematologist expert, Dr. Jumlin George. And again, Q&A for Dr. George and Dr. McMahon's presentation will happen after both of their presentations.
Use the clicker or the mouse, either one. Okay. Lovely. Good morning, everyone. And to kick off for this Denver ASH review, I will be focusing on 3 drugs that have a direct impact on our clinical work. One should be going to the FDA for approval. One has been approved by the FDA in a different indication, and one just got an FDA approval last month. I'd like to kick off things by discussing ianalumab in ITP in the second-line setting, or the WAY-HIT-2 trial. This is one of the studies discussed in the plenary session of ASH this year. There was also a simultaneous publication in the New England Journal. We were fortunate to have had this trial open here at CU. So ianalumab is this fully human IgG monoclonal antibody that has this dual mechanism of action. One way of depleting B cells includes the classical ADCC-mediated mechanism, which is your antibody-dependent cellular cytotoxicity. But it also has the ability to deplete B cells by blocking the BAFF receptor. Now, the BAFF receptor, which is a B cell activating factor receptor, is crucial for B cell activation, maturation, proliferation, survival. And in patients with ITP, it has been shown to be elevated. It's supposedly 40 to 70 times more potent than rituximab in depleting B cells and is in clinical trials in a wide variety of indications, predominantly in the rheumatology space and Sjogren's with SLE, and I know there's a phase 1 in CLL as well. For this trial, now this is a second-line trial, and so patients who are 18 years of age or older with a diagnosis of primary ITP and patients who had an insufficient response or a relapse after first-line steroids were eligible for the trial. An insufficient response was defined as a platelet count of less than 30 or the need for glucocorticoids for more than 8 weeks. And relapse is defined as a platelet count of less than 30 after an initial response. Now, if patients had any other therapy for ITP, they were excluded. Patients were divided into 3 groups, examining 2 different doses of ianalumab with 4 infusions in total. So you got ianalumab 3 milligrams per kilogram, 9 milligrams per kilogram, or the placebo, but all groups got eltrombopag for a total of 17 weeks or 16 weeks, and after which patients went into a tapering cycle of eltrombopag until discontinuation. From Promacta's first trial, in 2007 that was published by Jim Bussell, time to response was calculated at 43 days, but over here it was calculated as time to treatment failure, with treatment failure defined as a platelet count of less than 38 weeks after randomization. So you got 2 more weeks to account for that B cell depleting action of ianalumab. Initiation of rescue therapy more than 8 weeks after randomization, initiation of a new ITP therapy, any inadequate platelet count, or death from any cause. There were also many secondary endpoints, and this was defined as a stable response at 6 months with platelet counts of at least 50 at 75% or more of the measurements from week 19 through 25. CR rates, fatigue scores, immunoglobulin depletions, bleeding events were all calculated. All 3 groups are broadly similar. The vast majority of patients were under 65 years of age. It was multi-center. It was in multiple centers across the world. So you had white, Asian population, and the white and Asian populations are predominantly the races in this group. Patients on average had between 3 to 4 months on therapy after the initial ITP diagnosis. A few patients had TPO-RAs before screening, but you could be on a TPO-RA for about a week before the trial started. As you can see from this Kaplan-Meier survival curve, it was an overwhelmingly positive trial with the hazard ratio at 0.58 with a 3 milligram per kilogram dose, 0.55 for the 9 milligram per kilogram dose. And so what does this mean in layman's terms? It means in 12 months, the probability of being free from treatment failure was 54% in the 9 milligram group, 51% in the 3 milligram group, and 30% in the placebo group. I'd like everyone to remember that this placebo group still included patients who had gotten Promacta and kind of falls in line with historical estimates of treatment-free survival with Promacta alone. Looking at second-line endpoints, as you can see, a huge response rate in the 9 milligram per kilogram group, a 55% CR rate in the 9 milligram per kilogram group, a little lower with the 3, but still substantially higher than just Promacta alone. There were changes in the PROMIS fatigue scores. Seems to be trending towards the 9 being a better, seems to be better for as far as fatigue is concerned. In terms of bleeding events, which is always a question for patients with ITP, roughly similar at baseline, and at week 25, it was a lot higher, at least twice as much in the placebo and eltrombopag group. Since this is a B-cell depleting agent and an infusion, naturally, the first question is how many infusion-related reactions would you have to deal with? Patients did get steroids up to 50 milligrams of the first 2 infusions. And here in the adverse event table, you can see that the vast majority of patients had headaches. The rest of it has to do with how we grade for ITP. A few SAEs were not thought to be related to the trial dose. In terms of safety, in terms of infections, because this is a B-cell depleting agent, kind of similar between the 3 groups. So it doesn't seem to be too immunosuppressive, although there were more cases of neutropenia in the 9 milligram per kilogram group and 1 patient with persistent hypogammaglobulinemia. So to summarize, ianalumab plus eltrombopag led to a longer time to treatment failure than placebo with eltrombopag. More patients were able to taper and discontinue Promacta and maintain safe platelet counts. Fatigue improved in all treatment groups, but more pronounced in the larger dose and was well tolerated with similar infection severity and frequency relative to placebo. The second trial I'd like to discuss today was Ropeg and ET, and this is quite interesting because Ropeg is beginning to be used in combination with other drugs. With fedratinib, there was a presentation with fedratinib, there was a presentation with Rux last year to kind of improve splenomegaly, but this is a formal trial done in Europe. As you know, Ropeg has an FDA label for PV, but not for ET in the US. This is done in Europe and presented by Dr. Jean-Jacques Kiladjian. It was a phase 3 single-arm study, enrolled patients, adults with ET who needed cytoreduction but could not tolerate existing drugs. Ropeg was given every 2 weeks for 36 months. The endpoints were a durable hematological and clinical response after 12 months based on ALM criteria. So you had to have platelets less than 400, not 450, leukocytes less than 10, absence of thrombotic or hemorrhagic events. They also collected symptom improvement using this MPN symptom assessment form. So classically, the observed rates at 12 months were about 40%. They calculated a sample size of 117 patients, accounting for a few dropouts. This is a paper from 2019 for Dr. Jakob. As you can see in the red bars, this is the ET group in that paper. So 43% of patients had a CR, 69% ORR in that paper. Patients started at a higher dose than we would typically do for PV. If you're on hydroxyurea, as you know, we start at 50 plus hydrea. Without hydrea, you start at 100. But over here, they started at 125 every 2 weeks. If there was no response at 3 months, it was increased to 250 and then to 500 again, if no response. In total, they were able to enroll 132 patients, with only 3 discontinuations, but another 14 patients discontinued in 12 months. Baseline, there were more women on the trial at 58%. Patients on average had an MPN diagnosis for about 3 years. The average platelet count is 579. The distribution of mutations is what we would see classically for patients with ET, 60% with JAK2, 27% with CALR, 11% with MIPL, and 1.5% were triple negative. In terms of stratification, 40% were high risk, 28% of patients had a thrombosis or a hemorrhage. There were a couple of patients with splenomegaly. What was interesting was that 22 patients were considered, did not have any cytoreductive therapy and went straight to Ropeg. As one would expect with this trial design, everyone starts at that 125 dose. But what's interesting, at 9 months, 35% could stay on 125 mics. You didn't have to go to a higher dose, another 30% at 250, and obviously 23 and 9% at the higher dose. 48% of patients showed a durable disease response, so better than the 40% that they had expected based on historical cohorts. 65% had a durable peripheral blood count remission. 96% of patients did not have any thrombotic or hemorrhagic events. 100% of patients did not have any disease progression at 12 months. And this is sort of what we strive for in patients with ET. 5 patients, however, did have hemorrhagic or thrombotic events, with 2 being an acute MI and a TIA. Dividing this response rate by mutation, there was a slightly better response with CALR, and as everyone in the audience knows, these patients do also tend to have higher platelet counts and can be a source of anxiety for them. There was a decrease in platelet counts over time, a decrease in leukocyte counts over time. And in terms of symptoms, 87.7% of patients showed an improvement or non-progression of symptoms when compared to baseline. Now, when you start anyone on an interferon, one of the big questions is, can they tolerate it in terms of their psychiatric manifestations, right? Depression, asthenias, all of which can be quite taxing for the patient. What was remarkable, I think, in this trial was that there was no evidence of any flare in depression, or people having to stop the drug because of depression or psychiatric effects. And this is rather unusual, especially compared to my experience with Pegasus. I've highlighted the LFT abnormalities. They kind of split it out into different in the blue arrows. So 15% of patients had some ALT elevation. On average, patients had a mean weekly dose of 193, and it was a very low withdrawal rate. So remarkably well tolerated. And Kilagen has shown that you can sort of space out your dosing to once a month once patients have a response, and he alluded to that in the presentation as well. So for my last presentation today, moving to mitapivat. So mitapivat has just been FDA approved last month. It has a REMS program for LFT monitoring. It was studied in 2 trials. There was the ENERGIZE-T, which was the transfusion-dependent trial, and ENERGIZE, which was a non-transfusion-dependent trial. The non-transfusion-dependent trial was published at Lancet a couple of years ago. These results were actually presented at ASH last year. So patients got 100 milligrams twice a day and compared to placebo for 48 weeks, after which everyone got mitapivat with follow-up for 5 years. So last year, they showed that there was a transfusion reduction response, which is defined as a greater than 50% reduction in transfused RBC units and greater reduction of more than 2 units of transfused RBCs in any consecutive 12-week period. 30% of patients met that endpoint, a dramatic difference when compared to the placebo arm. I'd encourage everyone to, if you do treat thalassemia patients, to look at the presentation. I believe it's still available on Agios's website, because there are numerous other secondary endpoints looking at other responses in terms of transfusion requirements. So the updates during this ASH was sort of this open label extension, trying to understand how many patients achieved transfusion independence. In total, 17 patients achieved transfusion independence, with the mean duration of transfusion independence being 30 weeks. So that's about 7 months, quite dramatic. What's interesting is 3 patients here actually achieved transfusion independence, and that continued with this update for a total of 84 weeks. None of those 3 patients needed any more transfusions. So what does this mean for the patient? On average, the amount of annualized PRBC units dramatically reduced. There's a huge improvement. And then consecutively, we also have to worry a lot less when it comes to iron overload for patients on mitapivat. There was a tremendous improvement in transfused units. And that's it for today.